Good morning, everyone. I'm Dr. David Wild, Vice President of Performance Improvement and anesthesiologist here at the University of Kansas Health System, sitting in this morning for your normal host, Dr. Stephen Stites, our Chief Medical Officer. We're coming to you from the Dolph C. Simons Jr. Family Broadcast Studio here at the University of Kansas Health System this morning. With me on my left is a familiar face, Amanda Gartner, Director of Quality and Safety, Infection Prevention, and other things. Good morning, Amanda. Good morning. And on my right, the one and only, quite possibly infamous, Dr. Dana Hawkinson.
Infamous.
Good morning, right. Hawkeye.
Hi.
How many patients today here in the hospital?
We haven't been too happy this past week because our numbers have been up in the low 30s, and the total numbers in the hospital of acute and recovering have been around 60, but today is actually really good. I'm actually happy about this. Less hospitalizations are better. Today in the hospital for acute infections that we're actively managing, we have 22 patients in the hospital, down from like the low 30s, again, this whole week. 9 of those in the ICU, but unfortunately 8 of those are on the ventilator. We still do have 20 other patients in that recovery period that are still in the hospital, but it's much better. Overall, the numbers are much better than they were the rest of this week. Certainly, but in Hays, our partners out west, they have 23 patients in-house, and 1 of those is in the recovery period, so 22 active infections that they're managing right now.
That's, I think, a first, where the number of active patients here and active patients in Hays have been about the same.
Yeah.
And that's, of course, all couched in this week, where we've seen days, I think, of 10 new hospitalizations, even though the census has stayed in the 30s.
Right.
So lots of variability from day to day this week.
Yeah, and that's the important thing that we have talked about, even though our numbers are the same, and we did address this once again as well. There are discharges, but unfortunately there have been admissions as well, but most likely now, again, we've had more discharges over these past 24 hours, which is a good thing.
Well, this morning, the show is dedicated to answering your questions, like most Fridays, that we didn't get to answering earlier in the week. But first, I think we'll start off by asking if there are any reporters on the line who have questions.
I do have one reporter question, and it's from Channel 41. Charlie Keegan wants to know, he's going out and about, and there's a lot of sanitizing companies that are popping up using foggers and things like biostatic coatings to kill viruses, bacteria, and germs. They're claiming that it keeps viruses off surfaces for more than 30 days. So he has a 2-part question. A, is that true? Can that be true? And B, don't we need other germs to keep us healthy? So one of your favorites, actually.
Yeah. Germs? Yes. Do you want to take the question about that?
I can answer components of this question. So what we know about coronavirus specifically is that you don't necessarily need to invest in new technologies in regards to disinfection. We know that high-touch surfaces can be cleaned with any standard EPA-approved household disinfectant. And what's really critically important is hand hygiene before and after touching surfaces. That will be probably one of the most protective mechanisms. Claims in regards to keeping things clean for 30 days, I think, is impossible, because if you've got soiled anything and you touch that surface, it has to be there has to be friction applied to manually remove any of that bioburden. So in regards to that, I think that there might be some accuracy on claims based off of where it was studied, and maybe it was in like an environment in which it was very, very well controlled. But I think in general, I don't think it's realistic.
Yeah, I think it's difficult to know without knowing the context of the studies for that. But again, in general, the most frequent way and most common way that this virus is spread is by close contact. Certainly we understand that the virus in the droplets can fall to those high-touch surfaces. We know that it can live on those surfaces for a fairly short amount or fairly long amount of time, depending how you think. It's been several hours to several days. where they've been able to detect it, but really what is the concentration of that virus on that high-touch surface. And if you touch it, it's not going to be a problem if it's on your hands. It only becomes a problem when you start touching your face, particularly your eyes, your nose, your mouth. So again, to your point, really just using any common household cleaners can do that. If you can do these other measures, there probably will not be any downside to that if they are safe. We don't really understand the context of those other claims, but if more importantly is not meeting in groups, not being in close proximity, and if you are touching those high-touch surfaces, please be sure to do frequent hand hygiene. In fact, there was a recent study that that I may have mentioned before that they looked at on the skin surfaces, and actually the virus can stay on the skin surfaces for approximately 9 hours. It was a very small study, but that's about 8 times more than influenza can, and still be infectious. However, if you use hand sanitizer, if you use the alcohol gel, after about 15 seconds of using that, it is killed. So just doing all those things is important. If you are touching high-touch surfaces, remember to use good frequent hand hygiene.
Yeah, I think in the overall picture, there was a lot of concern about the risk of transmission from inanimate objects or surfaces early on.
Yes.
And I think while we've learned that the virus may live on a surface for a period of time, like you just described, I think we've also understood that that route of transmission, especially with good hand hygiene, is far less important than the things that we know. Gathering in groups that support droplet transmission, gathering in groups, not wearing masks, all of the things that the pillars of infection control are aimed to address. So,
That's right.
Great question. Okay, Jill is in the studio, and we'll continue to take questions from media and from viewers today too. So start sending those in, and we'll begin answering them shortly. Right now, I did want to take a minute and share some other numbers from our health system, some things about how the virus is impacting different groups, and also some numbers a little bit about how race and ethnicity plays into outcomes. So, I had the pleasure of speaking with a family member of a patient who had been COVID positive, been in our hospital. And that family member had a lot of questions about what differences in outcomes or treatments were important to consider based on the race or ethnicity of the patient. And we talked at length about that, and I thought that this was really interesting to share. So Dr. Stites and I reviewed this last week, and he said, this really needs to get out to the community. So first slide here, a lot of information. And we'll run through it, I think, in a way that helps understand. But basically, we're looking at the overall population that have been admitted to our hospital, sort of the overall column there, and then 2 different specific racial or ethnic groups, the African American population that's been admitted to our hospital, and then finally the right-hand column, the Hispanic or Latino population that have been admitted to our hospital. And I wanted to sort of point this out because overall, we've had 240 African American patients admitted for COVID to our hospital since March. And that's about 27.5% of the total admissions to the hospital. The average age of those patients has been 57, which is fairly comparable to the average age of the overall population. And then you can see here 37 of those 240 hospitalizations required a ventilator. And 17 of those hospitalized patients did not survive. And then you can see comparably what the numbers look like for the Hispanic or Latino population in those same categories. And what I really wanted to point out here was that if we look at the proportion of the overall Kansas City population that is African American, it's right around 29%. And so there's not a disproportionate number of hospitalizations for African Americans based on the proportion of our overall population. And really even the mortality rate is fairly comparable across these groups. If you look at the Hispanic or Latino population, however, right, a much smaller overall proportion, 10% of the Kansas City metropolitan area population is Latino, but still 27% or 28% of our hospitalizations, over a quarter of the ventilator use. So there is a difference in sort of the severity of illness in the Latino population, and it is younger than either the African American population or the overall. but the mortality rate, the death rate, is fairly similar across all groups. So that does help us, I think, tell the story that we pay attention to the outcomes and the impact of the treatments that we're offering to the overall population and to specific racial or ethnic groups to make sure that we are doing everything we can to reduce the impact of different non-medical, socioeconomic or otherwise, but different non-medical factors on the outcomes and care of our patients. So, Dana, Amanda, I don't know if that makes you want to add anything.
I don't have anything to add. I think you covered that really quite well, and I'm sure there will be questions that come from folks around that, but I think that's a really good overview of what's going on here.
Yeah, absolutely. I mean, the numbers, speak for themselves. We do pay attention, and, it's good to get those out there and be transparent about that.
So we were going to spend a little bit of time on ventilated patients as well. I know that's a question that keeps coming up. We'll bring that back only because there have been a couple of storylines over the past day or two from across the region, really the Midwest, and even the Kansas City metropolitan area that I think are really important to emphasize here today for all of you. So this slide talks or shows actually graphically in red the number of new cases per day in Missouri on the left and Kansas on the right. And then the blue shows the current number of hospitalized patients in Kansas on the right and Missouri on the left. And the message here, I suppose, in both states is that the number of new cases is just about as high as it has been at any point in the pandemic, maybe higher. And the number of hospitalizations is also at the highest point or very close to the highest point it has been. And we're hearing those stories from across our area. So we got a call from a hospital in Springfield, Missouri yesterday that they had more than 90 positive patients, which was a significant number, right? A much smaller hospital than we are here. We got a call from another hospital farther north in Missouri that had 68 positive inpatients, and their hospital only holds 230 patients. So very significant issues for these places. The following slide, the reason I wanted to sort of tell this story is the last slide here. This is per capita cases, so per 100,000 residents in a county. The darker the box means a higher number of new cases per week. This is 10 days old. So this slide is from 10 days ago talking about new cases. All of those areas that you see with dark shading here are now struggling with COVID hospitalizations, all of them. In fact, Minnesota and Wisconsin are talking about setting up field hospitals again, and the southern and central Missouri counties that are very dark are the areas around Springfield, Joplin, the Lake of the Ozarks that are telling us that they're seeing an increase in their hospitalizations to the point where it's concerning to them. They're calling and saying we may need to transfer patients because we're out of room. And so I wanted to make sure that we shared that message today, that this concern that cases would lead to hospitalizations and hospitalizations would lead to death, more deaths, we are starting to see across our region. Maybe not here at our hospital or even in the Kansas City metropolitan area right now, but we pay attention to these things very, very carefully. When we get calls like this, we want to make sure we are able to provide resources to help. So I just threw a lot out there again. I know, Dana.
But I mean, I think to your point, if you talked about the other hospitals' numbers currently, what would that proportion look like for our hospital if we had that? Because you had mentioned that at one point as well. How many patients would that be?
So even if we think about what we've seen in Hays, where 20 or 22 patients is 20 or 25% of their total capacity, if we had 20% of our hospital capacity here in Kansas City with positive patients, that would be 150 acutely positive inpatients. I mean, these are huge impacts on some of these hospitals.
Okay, ready for some community questions? That's incredible, that information you just shared. All right, so I'm kind of talking to the team in the control room. I got maybe two, maybe three real quick questions, and then we'll get to the slides. All right, so the first one is, we've got people that are asking, could you tell, speak to a decade in terms of ages as opposed to just average age? They want to know, are most of our patients 50 and older, 60 and older?
So since the beginning of the pandemic in March, our highest age band, if we're talking, is it 50s, 60s, 70s, 80s, the highest total number of patients needing hospitalization has been sort of in the 70s. Over the last 60 days, the 40 to 49 age band has actually grown to be the largest single age band in the terms of decades. That has also come with the storyline I think we've shared before that many of those patients have fewer comorbid conditions or chronic medical conditions. They stay shorter. They're leading to a shorter length of stay, meaning a census that's flat, even if we're seeing more hospitalizations. So I think that storyline changes a little bit based on the time period. We know we're not seeing, for example, here in Kansas City, the same number of long-term care outbreaks causing admission to the hospital. So I don't know. Dana, Amanda, things to add?
I think my comment would be really to the data that you presented and really highlighting that it is absolutely still out there and that we can't let our guard down in regards to the pillars that we talk about every day. I think there are some folks who are they're just over it and they want to go back to normalcy, and I think we don't know what that looks like, and so I think those numbers really highlight why we can't let our guards down.
Yeah, and I mean, the last time I looked was a couple weeks ago on the death rates and percentage. So I think between 65 and 85, that was a majority of our deaths. But we did have deaths in every other decade as well. So it does happen. But of course, the majority, as we've talked about, are definitely that older population.
And it probably helps to just reinforce today in our hospital, we have patients from 17 to 96, 15 this morning, to 96 years old who are here because they need care related to COVID. So while the age bands may matter and the averages may matter, no one is immune. We have seen a number of patients of all ages needing care here. Joe.
Suzanne really liked your map, Dr. Wild. She wanted to know, where do you find that?
So I can't take credit for it. That is actually, I believe, from... I have so many sources of these things. I think that this is from either covidexitstrategy.org or from COVID-19 tracking.org. In any event, if you look, you can find, Googling simply can find you per capita maps that show you trends. And again, this one I said is old. I specifically grabbed it because it was cases 10 days ago, and now we're seeing hospitalizations in these areas. But there is a significant amount of information to help you sort of digest, and we can continue to share things like this if they're helpful.
And Donnie wants to know, can the doctors discuss the 10-minute contact guidance? Specifically, is it accumulation? Like if I walk over to you, I guess, for a few seconds and then I leave and then I come back,
absolutely.
Or is it consecutive?
Sure. Who wants to
We've
start
definitely
there?
had these discussions. You want to start?
Well, we certainly have had these conversations, and I think that the guidance on this has been a little bit unclear. I think that the takeaway really is the interaction, the activity that is happening during that 10 minutes. Because the likelihood of a droplet being transmitted in that interaction is really what that timeline is based around. I don't recall if it really is the accumulation. I know we've had folks ask this question, like you just said, well, is it over the course of 24 hours? Is it the course of within an hour? Is it the course of a month that you have built up that 10 minutes? And I think I don't think that they've actually specified that. I think it's really what does that interaction look like? And
we had these discussions again with athletics too, because certainly during some athletics or practices or games you have and so I think there was some more of an accumulation of 10 minutes within an amount of time, whether that's 24 or 48 hours. It's not just a specific interaction, but it hasn't been very clear. The guidance are coming from different places, but there was some more landing towards the overall accumulation of that time within that 24 or 48 hours, which makes it very difficult for sure. But certainly if you are in close proximity to somebody for 10 minutes, but that doesn't mean that if you're in close proximity with somebody for 5 minutes that you can't get it either. That's the issue, especially if they are highly infectious at that point in time.
Yeah, and I think that's where I kind of struggle with that. The guidance is that is it 9 minutes and 58 seconds means I don't have to be quarantined?
Right.
And I think we have to be very careful and really thoughtful of think through that interaction.
Yep.
And if you are at risk, really kind of taking that personal responsibility of it probably is in the best interest of myself and the others that I'm going to be around to quarantine because I probably need that 10-minute contact.
Well, and I think it's also really important to say, sort of to the point that the 10 minutes is not a magical number. It's not
Right.
different
Correct.
at 9 minutes and 58 seconds versus 10:02. It's also really important to recognize that one cough or sneeze in a 30-second exposure to someone who's positive. If you are close and those droplets end up in your eyes or on other mucous membranes or even on your hands and then you transmit by touching your face, that you could transmit this disease in 10 seconds versus 10 minutes if you find yourself in those situations. So physical distancing, wearing masks, good hand hygiene, all those remain key, probably more so even than the time.
Sandy has a question, and then I promise we're going to go to the other questions that we had slated for today. But Sandy has a question that represents a lot of people that I'm seeing on the thread. And it's the story and the question of when do I go and get a rapid test or a PCR test? And the story is consistent with, in this case, to use the example, football player gets notified, hey, somebody on the team tests positive, you need to go get a test. Player goes, gets a test, it's negative. 2 days later, he's got symptoms. So everybody in the family goes and gets a test, they're negative. 3 and 4 and 5 days later, they're all having symptoms. Physicians are saying, well, must have been a sinus infection. Is it? When do you get tested?
Lots of good questions there. I think I'll make one point and then turn it over to Dana and Amanda. I think first we have learned, right, in a number of situations over the past few weeks, we've seen reinforced very, very visibly that a negative test at any point really means nothing. Because an hour later or a day later, that same patient with the same exposure 5 or 6 days previously could test positive. So I think the real important information here is that if you are positive, regardless of the type of test, you should isolate. If you have a significant exposure, regardless of a negative test, you should quarantine for 14 days.
Yeah, I think that was my main point was going to be that it's that quarantine for 14 days that is really the critical piece. We have seen folks who test positive within 2 days, within 4 days, within 8 days, and I think we've even had after 12 days test positive. So I think the point about getting tested really does help to identify when your isolation might start because you're positive, but it doesn't negate the necessity for you to quarantine for 14 days post-exposure.
Yep, that's a very good point. Now, in the context of the CDC recommendation for somebody who's a close contact to get tested, there isn't a lot of guidance. We haven't landed on exactly where, but we would probably say somewhere in that 5 to 8 day range when you want to go get tested. But even the negative test at that point at 8 days does not negate that 14-day quarantine.
Okay, so we have a lot of great questions, including people from Springfield. And Paul has a clarifying question, but we're going to walk through these that we already have prepared for today, and then if you guys are up for it, we'll take these last 2 or 3. Sure. All right, so once a vaccine is approved, will people be tested for antibodies before getting a shot? Why or why not?
Dana?
I would probably say no at this point. We know that the vaccines are probably going to be universal. We don't really understand what an antibody test would do if it is positive because we don't understand about the durable immunity that you have had if you do have a positive antibody test. So I have not heard or seen any guidance that we need to be testing for antibodies prior to getting the vaccine.
The president calls the antibody cocktail Regeneron a cure for COVID-19. Is that true? Why or why not?
Oh, another therapeutics question for you, Dana.
Yeah, I would say that is probably not true. I would say that there is not enough data to support that. In large-scale trials or large-scale amounts of data, I think it can help people, and it seems like it's helped. But we also have to remember it's going to be important to understand when do we give that in the time course of infection. It is probably going to be more favorable, and certainly we know from the Mayo Clinic studies on convalescent plasma that the signals for more favorable outcomes did occur if there were higher antibody titers, meaning levels of antibody. We know in these constructed antibody solutions, whether it's Regeneron or any other companies, those antibody titers are going to be very high, first of all. We also understand that there was a better signal if you were given that convalescent plasma within the first 3 days of symptoms, and then certainly as you get further out into the infection, it's probably going to be less beneficial. So it is not a cure. It will depend most likely on when you get it within the course of the infection. But it is one more thing we can use to help decrease the risk of that severe infection. But overall, we just don't have enough data to really understand what will be, how will it change the natural history of the infection right now.
And I was just going to say, I think we have to be really careful with the word cure and the application, that what might work for one person won't apply to everyone. So I think that's really important to keep in mind that, again, there's not enough data to call anything a cure at this point.
And really, that this isn't a cure, whether it's the convalescent plasma or a monoclonal antibody that is really an identified antibody that was circulating in plasma that's been synthesized, if you will, to provide really effective antibodies. Even then, it only works if you've already been infected. And it really is aimed at preventing replication and infection of other cells inside your body. So it's not really a cure even in that sense.
Yeah, it helps to give your body some sort of neutralizing antibody until your adaptive immune system really can work its way up to start producing those. And I think hopefully it should overall reduce the rates of hospitalization and severe critical disease and death, but there's just not enough data right now to understand that.
Okay, following up, the next question is kind of related. Are there any potential side effects to monoclonal antibody therapies? Do we know?
There is always potential side effects to any therapeutic. So that is what is to understand. So far, these therapeutics that have been tested out do look safe. The convalescent plasma was shown to be safe. But again, they are still very new. All of the number of people treated and all the data is still very small. It looks to be safe, but we still have to continue to watch and see where the trial and data goes. But overall, I think it should be probably a safe product, yeah.
Yeah, I think it's important to call out, too, that monoclonal antibodies as a technology for treatment are not new.
No, it's been used a lot.
Been used in other diseases for many years and are, I think, very safe options. But every time that we use something to augment or modulate the immune system, there are risks of side effects. So, well,
lots of cancer drugs for monoclonal antibodies, for sure.
All right. I tested negative after 1 week post-exposure to a COVID-19 positive person. Why do I have to quarantine for 14 days?
So we've touched on this already, but I'll toss it to you, Amanda, for reinforcement.
We know that the incubation period can extend to up to 14 days, and so that's where it's important that you have, not every person is going to respond the same way, and like we said before, we have cases where folks have acquired and become symptomatic within 2, 4, 8, 12 days. The CDC's guidance on that has always been quarantine for up to 14 days, so that it's the body's response to that infection. So, which differs by organism. In this case, 14 days is the magic number for quarantine. But as we've mentioned over and over, you can't test out prior to that if you have a negative test within that time period.
Yeah, and I think we all understand it's hard to be patient for 14 days, especially if you get a negative test and feel like that's additive information. And unfortunately, while it tells you you're not positive at the moment, that's really all it tells you. So,
are there many people age 70 and older who are asymptomatic?
We have had patients here who come into the hospital and as part of their admission screen are positive, and that wasn't the underlying reason in which they needed to be hospitalized. So I don't know the statistics by age group of asymptomatic versus symptomatic in that age range, but we know for certain that asymptomatic patients can be of any age.
Yeah, I mean, certainly we can't quantitate that, and we can't quantitate the number of people who are out in the community who are over 70. And not having any symptoms. But we have seen it here. We know that happens. I believe I saw a patient who was really asymptomatic in clinic for one reason or another, and they were asymptomatic as well. So we know it happens. It's just your risk of having symptoms and hospitalization is certainly higher in those higher age groups. But we have certainly, just as you said, we've seen it here.
Yeah, I think there are some sources of information. KDAG actually does a really good job of quantifying by age group for patients that they can reach and speak to repeatedly. what percentage of those patients they can follow up with are asymptomatic on their test date and are asymptomatic by the end of maybe a week or 2 weeks of illness. And in general, I think it is safe to say that the older age groups, 60s, 70s, 80s, have a smaller percentage that are asymptomatic, but it's not impossible.
All right, here we go. We're up with the ventilator questions. What are the survival statistics for people who are put on ventilators?
So I'll throw what I know without a deeper analysis out there, and I think we can bring this back as a more pointed topic sometime soon. But we've had 116 patients who've needed to be placed on ventilators. And that means roughly a third of those have not survived. So the mortality rate for ventilation is higher than the mortality rate for the ICU or mortality rate for hospitalization, maybe 30 or 35% compared to 6 or 7% for the general hospitalized population.
Do you think that's unique to COVID?
No, I mean, in general, being on a ventilator is absolutely a sign of more severe illness, and that your body, right, multiple systems in your body are likely failing, and so that is a statistic, I think, right? The mortality rate for ventilated patients in any disease is higher, and so I'm not surprised by that. Dana? Anything?
Yeah. No, I think it was in the different experiences in Italy and China, for example, it was probably different, much higher. In our early experience in the United States, it was probably much higher. But I think it's kind of really landed on, like what you said, probably in that 20 to 30% range once you are on the ventilator, just from our most recent published reports here in the United States.
Are they, and this isn't on here, but are they older people traditionally, or does it matter?
I think it's hard to say specifically. I'm trying to think if we've had any really young patients on a ventilator. Teenagers, I don't think so.
I can't think of any really young ones, no.
So it's probably true that they are generally older patients. We'll pull that into the larger analysis, though, for sure.
Okay.
I was going to say,
sorry.
the other component of that is many of these folks probably have an underlying respiratory disease process that puts them at a higher risk of being on the ventilator anyway. And you do see that, or that's been what I've noticed with our patients who end up on a ventilator.
That's actually a good segue to the next question, which is, how is it determined when a patient is put on a ventilator? Is there an average number of days this happens in their disease process? We had a lot of people asking that yesterday.
Yeah.
So is it like day 7? When I come to the hospital?
Yeah. Well, I wish we had, Dr. Satterwhite or Dr. Salate here to help answer that question. How is it determined when a patient is put on the ventilator? This was a little bit different. When people, again, were coming in early in the course of this pandemic, they would see that their oxygen saturation, meaning the amount of oxygen that they can detect in the blood, was very, very low. But patients didn't seem to be really struggling with breathing problems. So the Chinese experience was intubate them as soon as possible because their oxygen is so low. As we move further and further out, now the line of thinking is prevent ventilator as long as possible until it's needed for another reason. So there are different criteria, which includes oxygen in the blood, other vital signs and vital statistics as well. So they do continue to try and not use the ventilator, but what we call non-invasive ventilation, as long as possible, until really that last point where they can't anymore, and it will lead to further death quicker. So we try to avoid it as much as we are able to. When does that occur? We've kind of talked about this a little bit. What we see in the infection is that those first 7 days probably is really just the virus, the viral replication. Your immune system is adapting, it's building up, and then you start to have a reduction in the viral load. It's really that 10, 12, 14 day when you start to have that immune dysregulation, that cytokine storm, that ARDS that really then makes you more ill. And by that time we think and believe that the viral replication, the act of viral replication, kind of really has been stymied and put down by the immune system, and now you just have this large immune dysregulation. So that is really happening more probably at that 10, 12, 14 day mark.
And I think it's interesting or important to call out there that that doesn't mean 7 or 10 or 12 or 14 days after showing up in the hospital, because
Right.
many times people are infected for a week or more before they show up. So it can be day 2 in the hospital,
Yes.
and it can be day 10 in the hospital. It just depends on at what point in the infection you presented to the hospital.
I also think it's important to take into account whether a patient wants that artificial airway put in or not. So that is also part of that individualized patient care that we have to take into consideration. There are risks of being intubated or having that mechanical ventilation started, and some patients don't want to go through that, and so we also have to take that into account.
Very true.
So 2 more here, and then if you have time, I've got some new ones that came in. So what is the reinfection rate of COVID-19? Does anybody know?
I don't think we know that. This is a very good question. Reinfection, as we are now moving from March until now, typically, the reinfections that we have seen have tended to be longer from your initial infection. So not really the 90 days that I've seen, but more of the 120 or 4 months. We don't exactly know what this means in terms of the viral dynamics. Are you going to be more sick or less sick? We know from the rhesus macaque models, which are very small studies, that those monkeys did not get symptoms and had less viral replication. That does not seem to be true from the few published studies that we've seen on reinfection. One of the patients in Hong Kong had less symptoms and was asymptomatic. The other patient, from what I've understood, in Nevada, but I haven't seen the actual report, had actually more symptoms. And then I read a report yesterday about 2 other healthcare workers in India who had symptoms as well, but they seem to have the same amount of viral loads or more than they did the first time. So that really makes it important, number one, for the individual and how are you going to be feeling, but more importantly, are you going to be infectious to others? And that is where we just don't understand yet, and we are starting to learn about that. So overall, for reinfection, we don't have a lot of good information specifically for COVID-19, but we know for common coronaviruses that certainly reinfection can occur at, say, 9, 12 months, and even longer after you've had this same common coronavirus.
And you sort of dipped your toe a little bit into the next one, and that is, if you're reinfected, are you as sicker, not as sick?
I think hopefully we will start to get more published studies. It is difficult because for reinfection, we really want to be able to take your first isolate, do the genomic sequencing, take your second isolate, do the genomic sequencing, confirm that you've had reinfection, and then we just have to see. There's just been a paucity of cases and publications about that. We would hope you would be less sick. We would hope you would spread the virus less and be less infectious and have lower viral loads in your upper respiratory tract. But we just don't know that yet.
Okay, so it's 8:37. Do you have time for just 2 or 3 more we can
Sure.
walk through? Okay, they have great questions today. I want to go back to Paul. Earlier this week, and you'll remember because you were on the set, Paul has a 16-year-old daughter who tested positive. Now she's done, right? Mm-hmm. She's out of quarantine. She feels great. There's an 88-year-old grandmother that needs to be driven around. And we asked, was it okay? What Paul specifically said he's asking, is she the best person in the family to drive grandma because she's already had COVID?
I'll take a shot and then give it to you. So we do understand that you probably have some immunity after getting infection. We don't know how long that immunity lasts, and for different people, especially it seems if you've had mild or no symptoms, you probably don't have higher antibody titers right at that point. Do you have a memory? Are your memory cells there, and can you get a response if you should? Probably. But in the first few weeks or first couple of months after infection, those with less or no symptoms really have seemed to have less higher antibody titers. Is she the safest person because she's had it before? That's a good question to ask. If you're certain nobody else has had it, and nobody else has it currently, and she has had it and is within those few days, I'm not sure it makes a difference, especially if everybody can be masking as well. So I don't know your opinion on that.
Yeah, I would maybe even add, so, we've seen lots of times that people get a false sense of security, either from a negative test or the fact that they've had the disease before. And what we don't know right now at all, really, is if you've had it before, can you still be a carrier from a repeat infection? And by that I mean asymptomatic, reinfected 3 months, 4 months out, and be able to give it to other people even if you don't have symptoms. We don't know the answers to those questions. It's at least theoretically possible. And so I think I agree with Dana. The answer I would give is don't feel that that's a fail-safe, Paul, and do all the right things still. Wear a mask, physically distance, make sure that your bubble is small to help protect those that you're interested in making sure safe, whether they are your children, your spouse, or parents or grandparents that you help take care of.
Okay, Sharon from Springfield has started a really interesting discussion going on Facebook.
All right.
Where, as you pointed out, infection rate's pretty high. And she's saying they've been going to school 2 days a week. Now they're going to bring everybody back. And she's wanting to know, is that a really good idea? And then some people are saying, weighing in, yes, because they need to go back to school. And how can we help Sharon reconcile?
So complicated question, because I think there are answers that are related to how do we best prevent transmission of the disease. And those answers are probably in conflict and different with what is best for the education of our children. And so I think, right, from if we sort of think about our role in this and saying what is best for disease, reducing disease transmission, I think we would say that when you gather people, whether it's in the classroom or for an extracurricular activity, the more people that gather, the higher the risk of spread. I don't know.
Yeah, and I think, can you have in-class activities safely? I think you can, provided you are constantly monitoring that social distancing, that masks are being worn. My major concern with children wearing masks is the frequency in which they're touching it, and then their hands have to be constantly promoting good hand hygiene with that group. As I've mentioned before on the morning show is there are different activities within a classroom setting that might even pose more vulnerability in addition to just expanding the people that you're exposed to. If you're in close proximity, if you're eating or drinking, so lunchtime, I'm not exactly sure what recess looks like and if recess is a thing in school districts. But those are those activities that do pose a higher risk. And so having constant conversations with your students or your children about how important it is, and it's difficult. Those are, they want to be around their friends. It's a familiar environment, but they can't let their guard down. And so constantly reminding them in the importance of social distancing, wearing their masks, and good hand hygiene.
Yeah, de-densifying is important. If she said that people are bringing everybody back, the less amount of people, if you can de-densify as much as possible. How much spread is in the school, it's really difficult to say in that school setting where they do have systems in place for most of them. If you can do the masking, spreading apart as much as possible, we want to make sure not only the children but obviously the adults in that school are safe. Unfortunately, there is a lot of community spread, and so you can't control what those children or families are doing outside of the classroom. Because I know that they're still getting together. The children are either doing academics or getting athletics or doing play dates or something like that. That can be one of the major ways it's spread as well. Now, will they bring it into the school and could they infect other people or put people on quarantine? So put a whole classroom or half a classroom or a teacher on quarantine, things of that nature. Those are all the things to consider. But we know that even when school is not in session, there are a lot of things outside of school where people are gathering, and especially now in Halloween and Thanksgiving. There will be Halloween parties. There is guidance from the CDC. We have certainly recommended against having Halloween parties, having people come to your house, doing things of that nature, just because right now it just is so easy to spread this disease with any large group. So.
You remember back early in the pandemic when you talked about you couldn't tell maybe necessarily the difference between a coronavirus cold or the COVID coronavirus. And Jamie's got a question about that. She's saying, if I have a common cold right now, am I going to test positive for coronavirus, and will people think that it's the one that causes COVID?
Yeah. So currently in the hospital, we do use a respiratory viral panel, which has 15 or 16 targets on it for different viruses and I think a few bacteria. That does include the common coronaviruses, but that will not pick up SARS-CoV-2. Any of the molecular tests that we have, and we are hoping to get an influenza, RSV, and SARS-CoV-2 test soon, but it will not pick up the regular common coronavirus. Most people will not get that respiratory viral panel done for them. Again, mostly it's in the hospital. So to a quick answer to your question, if you get tested and you get tested for SARS-CoV-2 and it's positive, it'll be SARS-CoV-2. If you have the other common coronavirus or metapneumovirus or rhinovirus, any other virus that causes common cold, it will not pick it up. There will not be a false positive there for another virus.
Last question. There are a ton more, but I'm just going to tell everybody right now, they are so good. I'm going to carry them over to Monday. But I want to end with Emily, because I know you guys have got to go be doctors and such, and you got things you got to do too, Amanda. Emily says, it's been hitting us in central western Kansas really hard recently.
Yeah.
And while I know some individuals' attitudes aren't helpful, I do think we are unfortunate in the fact that it's making its way here. I think she's talking Western Kansas, after everybody already has cows.
Yeah, I know.
Their, coronavirus weariness. So, and she just wants to know, what can you say? What can she do to try to keep people keeping on?
So I think this has been from the very first episode that it is a personal behavior and a personal decision. So I think if she's wondering what she can do, she can continue to follow the pillars of infection prevention, wearing the mask, socially distancing, promoting hand hygiene, not going to large group gatherings, which is not fun, but it is safe, and we know it works. So I think anything you can do to promote or lead by example would be my recommendation.
Yeah, I mean, it gets hard. You know, we want to be together. We want to be with friends. We want to be with family. We want to go to Arrowhead. We want to go to the K. It is definitely difficult, but just because the virus hasn't gotten there or is now getting there, it doesn't mean it's not real. We understand this virus has jumped oceans and gone to the mountaintops, and the infections are real. It's just continuing to promote what you know is true, and that is things, just as you said, the non-pharmaceutical interventions, not gathering in large groups, wearing masks, physical distancing. That will keep you safe because this virus is real. And we don't want you to be afraid of it and fear of it. We want you to have knowledge to protect yourself, protect your family, and protect your loved ones.
Yeah, I've actually had the opportunity to be in both Hays and in Great Bend in the last 2 or 3 weeks. And I think the question is a very good one. Everyone, everywhere is tired, is weary, wants to return to some semblance of normalcy, something that feels normal. It's been a long time we've been dealing with this, and of course that's complicated if you're in an area that hasn't had a lot of impact yet and now is starting to see it. And I think the answer from all of our experts here remains sort of the same, is that we do know the things that we can do to prevent disease spread. We know it. They're the pillars of infection prevention, the same things that we've been talking about now for 7 months maybe. And I think acknowledging that they are simple things but hard things to do, especially when we really want to sort of move on from this, and I think everyone does. So very much appreciate the question. It's a great one, and empathize even with what that means for all of us. And I think keep on keeping on. I mean,
one day at a time.
All right.
All right.
Well, final thoughts, Dana?
I think those were it.
Yeah.
One day at a time. Try to get out and enjoy a sunset. Be thankful for the little things. Your health, the weather, anything. But yeah, it's one day at a time.
Yeah, I agree. I think we hit the highlights on the last question.
Jill was nice enough to hand me friends today who were experienced and knew where we were going and took care of all the work out of it. So thank you both. Monday, Nick Kinney with the Kansas City Royals and Mark Logan representing Comeback Kansas City join us to update and inspire us around getting flu shots. Kenny will tell us what's next for the Royals during this off season, and Mark will share the next big COVID-19 comeback story. And remember to send us your mask pictures. We really do look forward to how you're using your mask with or without your Halloween costume this year in an effort to practice the pillars of infection prevention and control and help us limit the spread in our community. Donnie sent this great couple's picture of mask wearing. I'm pretty sure the wolf mask is a costume, but it is appropriate during this Halloween season, and it looks great next to that bright pink. So keep up the good work. Send us your pictures. We like sharing them. And finally, Dr. Stites will be back on Monday. I promise he is healthy and well. We've had some people ask, and he's just busy with his other responsibilities, his full-time job as Chief Medical Officer here at the health system, and of course, as all of us, actively caring for patients. So have a great, safe weekend, everyone. Take care, and we'll see you next week.